we go. I'm going to explain to you how this works. Are you ready? Where is this? Where's the respiratory system? Jessica, that sounds very bronchitic. Yes, that's a pretty bronchitic cough. No joke. Okay. Where's the respiratory thing on there? Anybody see respiratory on there? How did that work? I'll find it. You just don't worry about a thing. Okay. All right. You remember that I explained to you that how PO2 and PCO2 affect hemoglobin saturation, right? Remember that? So, and then if you understand what the conditions are at the cell, then you'll know why oxygen falls off the iron and goes into the cell. And if you know what the conditions are at the lung, then you know why oxygen will bind there. So understanding those conditions is what's going to allow you to understand the oxyhemoglobin dissociation curve. That, ladies and gentlemen, is the oxyhemoglobin dissociation curve. All right? Now, this is what I want to point out. We talked about the fact that high PO2, that causes increased binding of oxygen, increased binding of O2 to the hemoglobin. And where do you find high PO2? You find high PO2 in the lungs, right? We also learned that low PCO2 increases that binding. And where do you find low PCO2? You find low PCO2 in the lungs. You also find lower temperature in the lungs, and you find a higher pH in the lungs. All of those things will cause oxygen to bind to the iron on hemoglobin. Now, watch. And this is really, from a clinical standpoint, why understanding this is important. Let's say, for example, you're working in the hospital, and you have a little old lady from Pasadena, and she's got a little fever of like maybe 101, right? And then you put the pulse ox on her, and her pulse ox is 82, right? Now watch. If you look, there is very little difference in terms of the saturation of a red blood cell. So look, here's the saturation of a red blood cell, and here's PO2. I explained to you that the PO2 of the environment is between 80 and 100, right? So even though you have a relatively large drop in PO2 from 80 to 100, the saturation of oxygen bound to hemoglobin is relatively unchanged. Now that's important because as you move in this world, up elevation or down, PO2 is going to change slightly, but it's not going to change enough where it's going to affect the amount of oxygen bound to the iron on hemoglobin. Are you following that? Now if you look, watch, from a PO2 of about 60, as you start getting down to a PO2 of about 60, you start significantly desaturating. So there's a sharp drop off in the curve. So if you have a patient and you put the little pulse ox on them, and their O2 sat is 80, then you know that their PO2 is about 50. And that means they're breathing the same air that you are. So their saturation should be up here. So something in their lungs is causing them not to get enough oxygen into the arterial blood. So it could be a pneumonia. It could be atelectasis, where the alveoli are collapsing. So if you were to see this on a patient, one of the things you would want to do is you want to check their lung status, right? Do they got gook in their lungs? Or you encourage them to cough and deep breathe because maybe they got a little mucus in their lungs, and just clearing that out will increase their oxygen saturation. My point is that if on your first shift your pulse ox was 90, and then you come in and the pulse ox is 82, that is a significant drop in the saturation of blood, assuming that she is getting the same amount of oxygen. And that is noteworthy, and that is something that the physician should be aware of. And then your job as a nurse is to try to improve her respiratory status, right? So cough and deep breathe, right? Have her read the textbook, because lifting that up, it's heavy, and the turning the pages, that'll help. Tell me you followed that. You got that. And then what happens is once you hit a PO2 below 50, like when you start getting into saturations in the 70s, you are running into really big problems, because the saturation of venous blood is about 70. So that means that you're not going to be dropping off a lot of oxygen at the cells. Say, yeah. All right. Let me just show you one more thing. And Kevin summarized it very well. So I will repeat what he said. Watch. Nurses, they love using big terms, and they probably really don't know what it means. So let me break it down for you. Here is the normal oxyhemoglobin dissociation curve. This is the normal. When you have a shift of the curve to the right, what that means is that for any given PO2, the amount of oxygen that's bound to the iron on hemoglobin is going to be less. So I'm going to write this out for you. Maybe I won't. A shift of the oxyhemoglobin dissociation curve to the right means that you pick up less oxygen in the lungs. So what is that going to lead to? That means that for any given PO2, that is going to lower your oxygen saturation. And what are the conditions that can cause a right shift in the curve, meaning it is more difficult for oxygen to bind to the iron on hemoglobin? Well, these are the conditions that are present at the cell. So a shift to the right is your total body is now experiencing the same conditions that you would have locally at a cell. That is a drop in pH, an increase in body temperature, an increase in PCO2, right? And an increase in hydrogen ions, which same thing as drop in pH, and then a decrease in PO2. Those are all the conditions at the cell. So it will allow the oxygen to fall off, but it won't allow the oxygen to bind in the lungs. Are you following that? Yeah or no? Well, try. A shift to the left. Where do you find conditions where the shift to the left occurs? That occurs in the lungs. Only the conditions that are normally in the lungs are now found throughout the entire body. What will cause a shift of the curve to the left? Meaning that oxygen will bind to the iron on hemoglobin, but when it gets down to the level of the cell, it won't let go. So for any given PO2, the hemoglobin saturation is going to be higher. So oxygen delivery to the cells is going to be less. And those conditions are a lower body temperature, a higher pH, higher PO2, and lower PCO2. Those are all conditions that are normally found in the lungs and that allows oxygen to bind. But now these conditions are present throughout the entire body, so when that red blood cell gets down to the cell, it will not let go. Say yes.
You said a lower PCO2?
Lower PCO2, right? Because you're getting rid of CO2 in the lungs. You got that? That's the oxyhemoglobin dissociation curve. Did you like that? How many people were really happy about that? You feel real good about it? Well, that's okay. Don't worry about it. You're learning. You know what that means? I don't know.
How do you read that from a pulse ox?
The pulse ox will tell you the saturation of the red blood cells. So if you have a pulse ox of, whoops, that ain't a very straight line, of 80, roughly, you know that your PO2 is about 50. So if that person is breathing room air, right, that room air is saturating their red blood cells about 80%. So that means that person needs supplemental oxygen. It's that simple. So if you look, most doctors will start giving supplemental oxygen when a patient is on room air at about 85. They'll start giving them supplemental oxygen. And what they want to do is they want to keep their oxygen saturation at 90 or greater. That's how they determine that. And I don't know if you've ever worked in the hospital where they're testing to see if somebody needs oxygen at home. So when they're going to be discharged, they take the oxygen off of them and they leave it off for about 15 minutes. Then they maybe ambulate around a little bit, right? And then they'll check their pulse ox while they're sitting there. And then when they're getting up, and if it drops to, I think it's 85, then Medicare will pay for supplemental oxygen. If not, then they go home with no oxygen. Did you ever see that? That's what they do. And that's why they do it. And, you know, if they have a fever and stuff like that, that's going to affect their saturation too. So you got to take all that into consideration. Okay. So that's why knowing it is important. And remember, a hemoglobin saturation of like 80 to 85 is not good. So that is that. Okay. Now what I'm going to do is I'm going to explain to you how oxygen and carbon dioxide are transported in the blood. And of course, I want this whole thing. Now, I explained to you, I know I did, that there is a law called the law of electroneutrality. Did I explain that to you? Well, I'm going to explain it to you now. And the law states that in vascular compartments, or the interstitial space, or the cell, the number of positively charged particles has to be equal to the number of negatively charged particles. And same for the interstitial space, and same for the cell. That's called the law of electroneutrality. Now, a red blood cell has a cell membrane. And because it has a cell membrane, it has to obey that law. So let's look at this. I am now going to explain to you how carbon dioxide is transported in the blood. And to get full credit for this answer, you will have to explain it completely. I'm now going over how carbon dioxide is transported in the blood. The first way that carbon dioxide is transported in the blood is dissolved in the plasma of the blood. That is referred to as the partial pressure of carbon dioxide. That's number one. That's the first way. The second way is bound to the amino group on hemoglobin. Many people believe, or used to believe, that oxygen and carbon dioxide competed for the iron on hemoglobin. They were incorrect. It is carbon dioxide binding to the amino group on hemoglobin, and it forms a compound called carb amino hemoglobin. So the second way in which carbon dioxide is transported in the blood is bound to the amino group on hemoglobin. That's number two. That would be the second way. Two. I'm now going to go over the third way that carbon dioxide is transported in the blood. I took a swig of my Diet Mountain Dew because my mouth was getting dry. Now I'm going to continue with the third way. As the PCO2 increases in the blood, that CO2, once it reaches that 45, that CO2 from the plasma will diffuse into the red blood cell. There is water inside a red blood cell. That's why I have water here. Carbon dioxide will combine with water, and a red blood cell is loaded with an enzyme called, I'll write it over here, carbonic anhydrase. Carbonic anhydrase takes CO2 and water and makes that chemical conversion into carbonic acid go faster. As we know, the carbonic acid will dissociate into free-floating hydrogen ions and bicarbonate ions. If these hydrogen ions remain free-floating, they can significantly reduce the pH inside that red blood cell. But those hydrogen ions will be loosely bound to the hemoglobin molecule, and the hemoglobin will essentially have buffered those free-floating hydrogen ions. So this explains how hemoglobin is also a chemical buffer. Now, what you have to do is you have to deal with this free bicarbonate. Bicarbonate is readily diffusible through the red blood cell membrane. And as you can see, there's a negative charge to that bicarbonate. And to maintain the law of electroneutrality, if a negative particle leaves the plasma of the red blood cell, then a negative charged particle from the plasma must go into the red blood cell. This is referred to as the chloride shift. So the vast majority of carbon dioxide is transported in the blood as bicarbonate. I know students, I've been at this a long time, and they love lists. So if you were to list PCO2, carbaminohemoglobin, and bicarbonate, you will not get many points. You will have to explain how bicarbonate is formed. We're not done yet. This blood now that has high PCO2, the CO2 bound to the amino group on hemoglobin, and bicarbonate, this is now venous blood. And all venous blood gets dumped into the right side of the heart. And the right side of the heart pumps it to the lungs. In this drawing, we have the alveoli. We learned the alveoli is a one-cell thick air sac, and the pulmonary capillaries are a one-cell thick blood vessel. Now, the PCO2 in the alveoli is 40, but the PCO2 of venous blood is 45. So the PCO2 is going to leave by pressure into the alveoli, and you will exhale it. As the PCO2 begins to drop, bicarbonate from the plasma will enter the red blood cell. That increase in pH as bicarbonate enters will cause the hydrogen ion that was bound to the hemoglobin molecule to fall off, and they will combine and form carbonic acid in the presence of that enzyme, carbonic anhydrase, which increases the speed of that reaction. It will then break it down to carbon dioxide and water, and the CO2 will move from high to low. Again, as bicarbonate enters, the chloride that entered at the cell leaves, right, to maintain that law of electron neutrality. And as the pH dropped as that went up as the bicarbonate entered, that will cause the carbon dioxide that was bound to the amino group to fall off, and you exhale it. So that's how carbon dioxide is transported in the blood. And to get full credit, I would like to be able to explain that process. Okay. All right. Hang on. My advanced class has their cardiovascular quiz Thursday as well. So that class starts at 9 o'clock, and then it ends at 11:10. So I'll try to get here about 12:30 if you wanted to start early. Okay? I'll let you know if I can't make 12:30. So look for an announcement on Blackboard if I'm unable to make it at 12:30. So make sure on Thursday, if you plan on coming in at 12:30, that you look on Blackboard before then to make sure that there's not an announcement stating that I cannot come in. Otherwise, I will be here at 12:30. Okay, let's review here real quick. If we look here, let's see what we have done. I've answered number 1, number 2, number 3, number 4, number 5, number 6, number 7. Did I go over number 8 and how breathing affects pH? Did I go over that? Do you remember? Well, let's review that. That's real quick. That's real quick. Okay. The reason we breathe indirectly is due to the buildup of carbon dioxide, but it's directly hydrogen ions. Now, in the alveoli, under normal resting conditions, the PCO2 is normally 40 millimeters of mercury. And the normal PCO2 is 45 millimeters of mercury. So if you begin to hyperventilate, so you are breathing faster and deeper than normal, and you're not producing any more carbon dioxide than normal, what's going to happen is that the PCO2 within the alveoli is going to go down because you are blowing it off more than you actually need to. So if you're hyperventilating, you're going to be blowing off more CO2 than normal. As a result, the partial pressure of carbon dioxide in the blood is going to be much greater than the partial pressure of carbon dioxide in the alveoli. And with that larger pressure gradient, it's going to allow more carbon dioxide to move out of the blood and into the alveoli by pressure. And we learned that CO2 is an acid. So if you mentally picture a CO2 equaling hydrogen ions, if you are getting rid of more CO2 than normal because you're hyperventilating, then you are getting rid of more hydrogen ions. And that's going to lead to an increase in pH. So that will cause a respiratory alkalosis. Now, on the other hand, let's say, for example, that you are not breathing as good as you should. And if you're not breathing as good as you should, then you won't be able to get rid of CO2. So the PCO2 in the alveoli, because you're not breathing good, that's going to build up. And let's say that it's 60 now. So watch. If the PCO2 is 60, right, and then your cells aren't any more metabolically active, CO2 by pressure will actually move back into the blood. And the result is that will increase your PCO2, or the amount of carbon dioxide dissolved in the plasma. And if you go with the idea that CO2 is an acid, then if you increase the PCO2, you will increase the amount of free-floating hydrogen ions. And that will cause a respiratory acidosis. Now, for the most part, people, they don't hyperventilate for 17 years, right? So the most common acid-base disturbance that you will see in your body is a respiratory acidosis. So as that breathing begins to decline, as we learned, nervous activity begins to become depressed. So that can actually make it worse because the medulla won't be able to stimulate the diaphragm, and it's kind of a snowball effect until they don't do well at all. So that is how increasing or decreasing ventilation affects pH. Okay. Now, since we're on this, this is, again, I try to go over something and then try to give you a clinical example of why it's important to know this. So, in DKA, your blood sugar is very high. You are either a type 1 diabetic who didn't take their insulin, or you're a type 1 diabetic and you're very sick. If you are sick, you have dis-ease, and that is going to cause the release of epinephrine from the adrenal medulla and cortisol from the adrenal cortex. And both of these hormones are designed to raise your blood sugar. Regardless of the cause, what's going to happen is this, is that the brain cannot use fat as fuel. So the liver, essentially, it assumes that you're starving with no glucose getting into it because you don't have insulin or, whatever. So the liver is going to take fat and it's going to convert them to the ketones. And those ketones are acidic. Beta-hydroxybutyric acid, acetoacetic acid, and acetone. And they will dump them into the blood. So as these keto acids build up in the blood, right, your pH is going to drop. Now, I hate to do this to you, so, and I'll take my time with this. So, if you look here, this is kind of like the metabolic side of the equation. Metabolic. Right? And this is the respiratory side of the equation. Right? We talked about this. So, if the cells of the body, through metabolism, are making more hydrogen ions than normal, in this case, in the case of DKA, it's going to force the equation this way, right? So the respiratory system is going to try to compensate for this metabolic acidosis. So if we remember that CO2 is an acid, so it's going to force the equation this way. So if you're making more hydrogen ions at the level of the cells of your body, in an attempt to maintain the pH, you're going to have to get rid of more hydrogen ions in the lungs. So you will have to get rid of more CO2. So if you recall, I explained to you that indirectly hydrogen, or indirectly it's carbon dioxide, but directly it's hydrogen ions. So as the pH begins to drop due to that diabetic ketoacidosis, well, I'm sorry, the pH is dropping, not the amount of hydrogen ions. Hydrogen ions have a difficult time diffusing from the blood into the cerebrospinal fluid. It doesn't diffuse as readily as carbon dioxide. So that's why in people with DKA, their breathing is very irregular. It's fast and it's shallow and it's just kind of irregular. So that's an attempt to maintain the pH of the blood due to a metabolic problem. Okay. All right. I explained to you cystic fibrosis, yes? Did I explain to you the chloride and I didn't explain that to you? Okay, let's go over that one because that one's pretty quick. Let me check real quick. That's number 13. Number 13. CF is cystic fibrosis. I don't know why I didn't even write that. That's cystic fibrosis. Cystic fibrosis was first identified in patients based on the fact that they would have scar tissue in their pancreas. So it's not cysts found in the lungs, it's actually cysts on their pancreas. So, hang on. Let me do this. Okay, just so you know about the videos that I try to make from class, I've downloaded all the videos I have based on the ones that I've saved. So if I'm missing a class from your class or anybody, there's nothing I can do about it. I have no more videos left. You know, I had to. With the new computer, they wouldn't allow me to download it and publish it, so I had to copy it to this thing and then download it with the computer that I got. So it just took a little longer time than normal. Okay. All right. So remember that the lining of the respiratory tract is very vascular, and the cells that line it are simple columnar cells that are ciliated. Just 1 second here. Oh, there it is. Okay. Let me try this. So, in people with cystic fibrosis, again, these little ion channels, they just rear their ugly head everywhere. When the goblet cells are responsible for making mucus. Now, when the mucus is formed, it's rather viscous. However, embedded in the cell membrane of goblet cells are ion channels. There's a chloride ion channel and then a sodium ion channel. And when the mucus is made, the chloride will leave through a chloride channel. And then to maintain the law of electroneutrality, the sodium ion will lead through a sodium channel. And that will draw water out of the blood into the mucus, making the mucus less viscous. Now, the result of this in people with cystic fibrosis is there is either a permanent lack of chloride channels, or there is a dysfunction in the protein configuration of those chloride channels. Either way, doesn't matter. The chloride channels don't work. So when the person makes the mucus, the chloride will not leave. And if the chloride doesn't leave, the sodium doesn't have to follow to maintain that law of electroneutrality. Therefore, when sodium doesn't leave, water is not going to follow. So the mucus that they make is very, very thick. And that thick mucus is difficult for the cilia to move. So this mucus begins to build up in the lungs, and they are prone to respiratory infections. Matter of fact, these people take prophylactic antibiotics all the time. So any part of the body that produces mucus is affected by cystic fibrosis. So that includes the digestive tract and the reproductive tract, to name a few. So they're usually, women are infertile, right? They can't get pregnant, they can't move the egg, and guys can't move sperm from the testes through the vas deferens. So they're not sterile, they're infertile, I guess you could say. So either way, they typically can't have kids. So that's cystic fibrosis.
Is that from birth?
Yeah.
There's no cure, no treatment?
The hope is gene therapy, where they can alter the genetics. They take a virus. You've had microbiology, so you probably learned about this. They use viruses as a vector, and these viruses will infiltrate a cell, and then they alter the DNA of the virus to have the correct gene sequence, and then the virus will actually implant that DNA into the human genome. And the hope is that they make correct chloride channels. That's still a little ways off. Right now, it is the treatment is palliative. They treat the symptoms, and they usually live to the ripe old age of about 35. They're living longer now. Have you ever seen those little percussion jackets that they wear? They just beat on you, right? And that beating on the chest will loosen the mucus. And then they have to take these inhalers and stuff that, there's actually drugs out there, it's called Mucomist, that will make the secretions a little less thick. So you've heard of Mucinex? It kind of works along the same lines. Okay. Do you want me to show you how they diagnose it or no? Do you want to know it or no? You don't have to include that in your answer. All right. Okay. So that's cystic fibrosis. Tension pneumothorax. Hang on. Oh, did you want to know that? Okay. Hang on. Okay. I went over this, didn't I? Are you sure? I think I did. Yeah, that's what you do. Okay. Uh, the skin has sweat glands, and then you have the sweat duct, and that goes to the surface of the skin. All right. So what I'm going to do is I'm going to take a little piece of the sweat duct, and I'm going to blow it up on a different slide. Okay. So this is the surface of the skin. And then this is sweat gland and a sweat duct. And then you have a blood vessel here. Now, normally, and especially in people who are in really good shape, due to the effects of aldosterone, let's see, when you sweat, sweat has water, it has sodium, it has chloride, it's got electrolytes, stuff like that. So when you sweat, what will happen is the chloride will get reabsorbed through a chloride channel, and then sodium will get reabsorbed through a sodium channel, and then water will get reabsorbed by osmosis. However, there in the sweat duct there are these things called aquaporins, and there's very few aquaporins in the sweat duct. The result is that even though you're absorbing sodium, water is relatively impermeable. That's why people who are in really good shape get that aldosterone effect, and they reabsorb the electrolytes where only the water ends up on the skin. Now, in people who have cystic fibrosis, again, wherever you have these chloride ion channels, they're either dysfunctional or absent. The result is chloride can't get reabsorbed. To maintain the law of electron neutrality, sodium will stay with that chloride, and the result is that the amount of sodium and chloride on the skin increases. So what they do is they inject usually the volar surface of the forearm, and they give them a drug called pilocarpine. And pilocarpine is a parasympathetic blocker. So it blocks the parasympathetic nervous system. So now you have sympathetic stimulation to that sweat gland, and it will cause that local area where that medicine was injected to begin to sweat. And then they take these little coffee filters, basically, and they collect the sweat, and then they measure the concentration of salt in the sweat. And if the amount is X, I forget the number, then that's diagnostic criteria for cystic fibrosis. And it's referred to as the sweat test. So if you hear of a sweat test, that means they are checking for cystic fibrosis. That's the test they
Is
use.
it the opposite of what happens in the lung? There's no sodium and no chloride coming out.
Right. There's still no sodium and no chloride coming out. Yeah. Okay, so let's go on to tension pneumothorax. Tension pneumothorax is a life-threatening condition. It is different than a spontaneous pneumothorax. A spontaneous pneumothorax can happen in people with lung cancer or a condition called sarcoidosis, where you get basically scar tissue formation in cells that have type 1 cartilage in it. But anyways, let me just do this real quick. So if any of you have a desire to work in the emergency room or critical care, you need to understand this a little better. Find this first. Here we go. All right. Now, outside of your nose and your mouth, the respiratory system is a closed system. And we also talked about, that's a terrible color. We also talked about the fact that within the pleural space, so this space between the ribs and the lungs themselves, that pleural space has negative pressure, right? This is what prevents us from breathing or blowing out all of the air in our lungs. So there's like this little vacuum there. Now, if someone has somebody stabs you with a knife, or somebody stabs someone with a knife and they come into your emergency room, one of the things that you don't want to do is you don't want to pull that knife out. The reason you don't is because a knife cuts both ways. It cuts on the way in and then on the way out. And if the person is still alive, you don't want to be doing that until you're sure that there's no major blood vessels around there. Otherwise, that person can bleed out very quickly. So once you pull the knife out, this person has a hole in their lungs. They have a hole in their rib cage. So, and you can test this at home, or maybe like when you go to the bathroom or something, don't do it when people are looking. It just looks kind of weird. But if you take a breath in, the distance between your ribs increases. So that hole in your lungs or in your thoracic cavity, the rib cage, will actually get bigger. So air from the outside will now come in through that hole. It will get sucked in. When you blow the breath out, the distance between those ribs decreases, so it can actually cut off that hole. So with each successive breath that you take, it will cause more air to get into your chest. And what it will do is it will begin to compress your lungs. The tension pneumothorax, the tension portion of this, is that the air keeps successively getting trapped with each breath that you're taking. So, and as you know, the heart lies in the mediastinum. So if it's bad enough, it will actually begin to compress the heart, and the heart won't be able to fill, so they can actually die from what's called cardiac tamponade. So what do you do? Well, let me show you. What's that? Yeah, they'll do a chest tube, but in the field, what they'll do is what's called it's called a needle decompression. Have you ever heard of that? Oh, wait, where is it? There's really actually a really cool video on this. Yeah, they can do that too. This is from the Medical College of Georgia. This guy is from Kiev, Ukraine. So there's the inside of the chest. They've inserted this needle. This needle has a one-way valve on it. It will only let air out. It won't let air in. So the air is moving out as this guy is trying to breathe, and then this is a lung, and then the lung will start to reinflate as that air is removed. You can actually see how the air is actually compressing one of the lobes of the lung. And then once they get that, once they've reinflated the lung and removed most of the air, what they'll do is they'll insert a chest tube to suction, and that chest tube will suction out that air until they can do a chest x-ray and make sure that the lungs are completely inflated. And then once they are, then well, what they do is they put Vaseline gauze dressing over it, and that Vaseline is kind of yeah, it's like a yeah. There you go. There you have it.
So where they insert the tube?
Usually because air floats, the lung typically gets compressed from the apex down.
They wouldn't put it in an intercostal space?
Yeah, they do.
That's what I was thinking.
Yeah.
So like why is it that weird pen thingy didn't pop the lung as it was
They use a plastic catheter over a needle. So they insert the needle over the catheter, and then once they're in the thoracic cavity, they withdraw the needle, and the plastic catheter just stays in there.
So it won't pop it if it's too hard?
No, it'll actually bend. If you saw it as it was inflating, the catheter was bending a little bit. You don't have to look at that. You can look at that on your own. Okay, so that's a tension pneumothorax. Now, if you look, where is that? This is a chest x-ray of someone who's in really bad shape. You can tell they're in bad shape. There is a Swan catheter in here. These little wires are EKG wires, and you can see the outlines of a chest tube and an endotracheal tube. Now, when you take an x-ray, x-rays are really good at looking at solid objects in the body. The most solid objects you have in the body are bone. So x-rays will absorb, our dense tissue will absorb x-rays, and tissue that is less dense, like air, doesn't absorb any x-rays. So as you can see here, this is kind of the outline of dude's right lung, and you see how this is all dark. This is all air. So this x-ray shows the lung collapsing, and if you also see, the heart is supposed to be over here. Here's his vertebral column. His heart is pushed way over here and it's beginning to compress this lung here. So he has a really severe tension pneumothorax, and that's not good. So that's why they use the chest tube to suction and all that stuff. Okay. All right. So that's the treatment. So the real two treatments for tension pneumothorax initially is a needle aspiration, and then to make sure that all the air is out of the lung, then they will use a chest tube to suction. And then once they find out that the lung has re-expanded, then they pull that chest tube out. Just a quick note of caution. They suture those chest tubes in with a loop suture. When you're going to pull it out, make sure that you clip the suture first. Some nurses don't do that. Okay, carbon monoxide. Now, carbon monoxide is a colorless, odorless gas. And I always get this confused. So to give you correct information, I'm going to look it up. Is carbon monoxide heavier than air? The myth that carbon monoxide should be installed on lower lung, because is right. Right, carbon monoxide is slightly lighter than air. It's lighter than air. So that's why you should have CO2 monitors, right? You want them up a little bit, not on the bottom by your furnace and stuff like that. And that's why in miners used to have birds in cages, and they would hang them up. And if they looked around and the bird was dead, then they knew that they had to get their fatty acid out of there because carbon monoxide was building up. So basically how carbon monoxide kills you is this. Hold up. Just do this. Carbon monoxide competes with oxygen for the binding of the iron on hemoglobin. So you have the red blood cell, and then you have the hemoglobin molecule, and then embedded in the hemoglobin portion of the hemoglobin molecule you have iron. For purposes of brevity, I am only going to make one iron, but we know that there's 4. So when you breathe carbon monoxide and oxygen compete, bless you, for the iron on hemoglobin. Both will produce a red colored hemoglobin. So interestingly enough, if you've ever seen someone who has died from carbon monoxide poisoning, they look particularly healthy. They have nice rosy red cheeks and ruby red lips, but they're dead. So how it kills you is this. Carbon monoxide binds with a much greater affinity to iron than oxygen. What that means is that when that red blood cell gets down to the level of the cell, carbon monoxide does not let go. So every time that blood circulates and a carbon monoxide molecule has bound to it, there's one less place for oxygen to bind. So that means that every time a carbon monoxide molecule binds there, there's one less oxygen molecule that can bind. So that's why if you see people who have survived a fire or even carbon monoxide poisoning, the first thing they do is they take them out into the fresh air and then they'll put oxygen on them. So if you recall, the oxygen of room air is 160 millimeters of mercury, so the PO2 in the alveoli is about 100. So what you want to do is you want to increase that pressure of oxygen to try to drive the carbon monoxide off the iron on hemoglobin. And if it doesn't work with 100% oxygen, we'll take them to a hyperbaric chamber where they can pump the PO2s up to 6 or 7 times normal. And that will literally force the carbon monoxide off the iron, and then the oxygen can bind there. So this is how people asphyxiate themselves. They are circulating blood. They're just not delivering any oxygen. So that's how. The pulse ox will read, right, that they are oxygenating really well, because how pulse ox works is it takes an infrared light and it runs it through your finger, and then based on how much of that light comes up on the other side, that gives you a reading as to oxygen saturation. So a pulse ox is not a good indicator of oxygen saturation when people are exposed to carbon monoxide.
Does it feel like would you have any idea like when this is occurring? Does it feel like you're suffocating?
No, what will happen is you will first start to get dizzy and lightheaded, and the carbon monoxide and the lack of oxygen will affect the medulla, and you will start throwing up.
Really?
So if you have a pet that's throwing up, right, and they're acting goofy, you need to go. Yeah, and then you die. Yeah. So
I'm just wondering, what in the detectors lets you know that it's like too much in your house?
there's little carbon monoxide detectors, and there shouldn't be hardly any carbon monoxide. Very, very low, like 0.01 parts per billion, right?
Isn't that the gas that's like from your stove?
Yeah, it's any fossil fuel, right? So, you know, if you have natural gas, right, a internal combustion engine, a car, you know, things like that. So it usually happens to young kids whose parents won't let them have sex in the house, so they go into the garage, turn on the car. They bump ugly for a little bit, and then they end up waking up dead. That's how that works. So the treatment for carbon monoxide poisoning is high levels of oxygen. You'd like to get as 100% if you can. And if that doesn't work, then you place them in a hyperbaric chamber where you can pump up those PO2s. All right. Okay, go ahead and take a break and then come back, and then we'll finish up. What's it? I don't even know what that is.
You're gonna post this recording
Okay, so uh, all right. Okay, so I explained the tension pneumothorax, carbon monoxide, pulmonary function curve. Okay, the number 7 you know, right? Or number 17, I should say. Oh, yeah, you know that one, right? Yeah, that'll be on. I don't know. It might be.
Oh, because you're gonna knock some off anyways, right?
Yeah, yeah. All right. Yeah, that's surfactant. It's made by type 2 alveolar cells in the alveoli. And it's usually not significantly produced in large amounts until the 7th month. But there's a synthetic surfactant that they can give the mother if they know the baby's going to be premature. It's called Surfacan. Or if the baby's born premature and unbeknownst to the doctor or the mother, then the baby can be placed on a ventilator short term, and then Surfacan can be given down the ET tube, so they only have to spend a little amount of time on there. So it reduces the surface tension between water molecules and prevents the alveoli from collapsing. Okay, let's see. Am I? Yeah, I am. Okay, so the pulmonary function curve. I'm going to explain that now. Okay. Let's see. Let's just do this. Okay, these are some of the terms that you're going to have to become familiar with. All right? So make sure that you understand these terms. These are terms that are used in respiratory therapy, and it's important that you understand them. So what I'll do is I'll give you time in class to look them up. Okay? Because they're pretty straightforward. So you have tidal volume, then you have residual volume, VOL is an abbreviation for volume. Let's see. Then you have inspiratory reserve volume. You have expiratory reserve volume. Then you have forced vital capacity. In your book, it may just be vital capacity, but when you do a pulmonary function test, you actually force that air out. So that's why it's referred to as forced vital capacity or just vital capacity.
What are these terms for?
These terms are for to understand the pulmonary function curve. So to understand the pulmonary function curve, you first have to understand some of these terms. So what I will do is I'm going to list the pulmonary function terms that you should know. And then after you take your quiz on Thursday, so on that following Tuesday, because then you won't have to worry about the cardiovascular system, right? I'll go over that so you'd have time to look these up, so it makes a little more sense. Does that make sense? So you have the forced vital capacity. Then you have what's called the forced, bless you, expiratory, bless you, volume in 1 second. And then you'll have to understand the ratio of this forced vital capacity in 1 second, or forced expiratory volume in 1 second, that is abbreviated FEV1, and then forced vital capacity is abbreviated FVC. So what physicians want to know is, in forced vital capacity, how much air can you take in and maximally blow out with one breath? And of that air that you can take in and blow out with one breath, how much of that air can you get out in the first second? So that's why they look at what's called the FEV1 to FVC ratio. That will give you an idea of whether or not this person has an obstructed airway pattern. So let me give you an example of this. Most people, when they have respiratory problems, it occurs in the lower airways. So I'm going to talk to you first about chronic bronchitis, and then I'm going to explain to you why giving these people high levels of oxygen can be deadly. So you've probably heard of this. You've probably heard of COPD, chronic obstructed pulmonary disease. Some people refer to it as cold, chronic obstructed lung disease. Those are two terms. Regardless of the terminology, the problem with people with COPD, they can't get air, that says air, out. So the amount of air left in their lungs increases. So they develop an increase in residual volume, or the amount of air left in their lungs after they try to blow all that air out. And they run into problems, to be sure. Let me just find this real quick. Okay. Where is it? Okay. Oh, wait, this is the right. What happened? So this is a person with emphysema. And emphysema is a COPD. So they have the barrel chest where the ribs actually, and the chest itself, the chest cavity actually expands to accommodate that increase in dead space or residual volume in the air, so that air is trapped in their thoracic cavity. As a result, the most common cause is usually cigarette smoking or a chronic exposure to something that is irritating or toxic to the lungs. So that's that. So I'll let you look over those values, those terms, and that way it becomes a little more meaningful if you understand those terms. And then if you look at the pulmonary function video that I put up, and then how you clinically correlate the values of a pulmonary function test to a particular pathology, that should make it a little clearer. All right, what I want to do for you now is want to go over, where is it? Explain why people with chronic bronchitis should not be giving high levels of supplemental oxygen. All right, so first of all, what's that? I can't hear you. No, not necessarily. If you recall, most people breathe not because of low levels of oxygen, but rather due to elevated levels of carbon dioxide indirectly, and then it's directly hydrogen ions. So, but here's the thing. So if you look here, if this is a bronchiole, and then the bronchioles branch into alveolar ducts, and then you finally have the one cell thick membrane, these clusters of alveoli. Now, in normal physiology, in normal people without pathology, lung pathology, there is a 1-to-1 ratio between ventilation, moving air in and out of the lungs, and perfusion, or blood flow to the lungs. As we learned with our discussion in the fetal circulation, we learned that high levels of oxygen in the alveoli, that leads to a pulmonary arterial vasodilation. And again, as a result of oxygen coming into the alveoli, right, through you breathing, that is going to cause the pulmonary vessels that supply that group of alveoli to dilate. And as we know, blood always takes the path of least resistance. So whatever alveoli you are ventilating, and we don't ventilate all of our alveoli, obviously you're not using up all your respiratory reserve at rest. Whatever alveoli you're ventilating, you should perfuse. You should send blood flow to. So, and of course that makes sense. So if you look here, and the mechanism for the pulmonary arterial vasodilation is different in the pulmonary vessels than in the systemic vessels, because we know that high levels of oxygen will actually cause constriction in the systemic circulation. And it has to do with the enzyme that's involved in releasing calcium. It's called phosphodiesterase. Anyways, you don't need to know that.
Is that 1-to-1 ratio of ventilation for perfusion only for the lungs, or is that for all the organs?
No, it's for the lungs, because the distribution of blood flow to the body is never 1-to-1. It's based on demand. So when you start exercising, you have to breathe deeper and faster. And when you breathe deeper, that's going to supply more oxygen to the alveoli that you weren't working, and that will cause more pulmonary arterial vasodilation. So, and when you're exercising too, you're contracting muscle, and that will squish more venous blood back to the right side of the heart. So you're increasing blood flow to the lungs by contracting your legs, and then you're sending more blood to the lungs, but at the same time you are ventilating more alveoli. So that 1-to-1 perfusion ventilation ratio is maintained. So if we look here, you got these capillaries. Now, that CO2 is high, so whatever alveoli you ventilate, you're going to perfuse, and that allows gas exchange to occur. Now, again, this is normal lung function, right? So it's 1-to-1. This is what allows you to maintain your PO2, PCO2, pH, and O2 sat of the blood when you're exercising. So those things shouldn't change much because you are simply sending more blood and you're using more of your lungs to perfuse and ventilate the lungs. So in clinical, you're going to see what's called a VQ. You've probably heard of a VQ scan. Have you ever heard of a VQ scan? No? Well, you probably will at some point. A VQ scan is really a test to look at whether or not somebody has a pulmonary embolus, to see if they're ventilating but not perfusing, that something's blocking a pulmonary artery or something. But anyways, this is normal physiology. Now, in people with chronic bronchitis, and the most common cause of chronic bronchitis is cigarette smoking. So this is what happens. It is inflammation of the bronchi and the bronchioles, so that secondary and tertiary levels of airway. And to simplify it even further, what happens is this. Regular cigarette smoking does two things. It paralyzes cilia, and it increases, it causes hypertrophy of goblet cells. So goblet cells actually get bigger, and they increase in number. So these people are making a lot of mucus. So they paralyze the cilia, so the mucus can't move, but now they're making more of that mucus. So that mucus tends to lodge itself in the lower airways. So if you look, where is it? Where did I do this? Where did I do that? Did I do it here? Oh, okay. So watch. What happens is this, is that there is buildup of mucus in the lower airways. The result is that you're not going to be able to ventilate these, but in people with chronic bronchitis, they still perfuse these for reasons unbeknownst to me. So they're going to perfuse these, but they're not going to be able to get any oxygen, and they're not going to be able to get rid of any carbon dioxide. So the carbon dioxide does not leave the blood, and the oxygen doesn't enter the blood. In the alveoli that are opened, you're going to be able to participate in gas exchange here. But when all of that newly oxygenated blood comes back to the left heart, it is going to be higher in carbon dioxide and lower in oxygen, simply by virtue of this ventilation perfusion imbalance. No ventilation, but they are perfusing it. The result is that you're going to hold on to more carbon dioxide and you're going to get less oxygen. Now, if we look, we learned that the primary center for breathing is located in the medulla. So what happens over time to people who develop chronic bronchitis is that the central chemoreceptors in the medulla become desensitized to high levels of carbon dioxide. So over time, the medulla just says, look, you're always building up CO2. I'm not going to believe it anymore, so I'm just going to ignore it. So the medulla doesn't really become the primary respiratory center. But we talked about the fact that where is it? It's up here. And I know it's here. Oh, there they are. That you have chemoreceptors, peripheral chemoreceptors that can affect breathing, heart rate, and blood pressure. And they're located in the carotid arteries and the arch of the aorta. They are called carotid bodies and aortic bodies. And these guys are chemoreceptors, right? Oh, it's right there, chemoreceptors. Now, and if you remember, I explained to you that they are sensitive to elevated PCO2 or hypercapnia, low PO2 or hypoxia, or and a decrease in blood pH. And that's the same thing as saying an increase in hydrogen ions. But again, even these peripheral chemoreceptors become desensitized to that elevated PCO2 because it's chronic. They always have it. So instead, these people with chronic bronchitis breathe by virtue of low PO2. So they're breathing due to lack of oxygen, not due to the buildup of carbon dioxide. So if you give them oxygen, what's their stimulus to breathe? It's low PO2. So if you give them supplemental oxygen, then that will raise their PO2 and take away their stimulus for breathing, and they will stop breathing. And I've seen a couple of nurses do that, and the patients stop breathing. And, you know, that's not good. That's bad. Usually you don't have your job after you kill somebody. About 80% of the time. Yeah. That's why you don't. That's why you don't. Okay. So what we'll do, let's do this. Let's leave it right there, shall we? And then on Tuesday, do me a favor. Make sure you print off the kidney stuff. We'll start that. And then I'll explain to you the pulmonary function curves. And we'll start going over the kidney. All right? Okay, don't forget, make sure that you bring your take-home quiz in on Thursday, completed. Okay? And I'll do my very best to try to post